Yeah, good afternoon, everyone. I'll be speaking about cardiovascular profile in diabetic kidney disease, insights from an Indian cohort. Introduction. Rising type 2 diabetes prevalence has increased DKD, a major cause of cardiovascular morbidity and mortality. DKD markedly elevates cardiovascular risk via oxidative stress, hemodynamic changes, dyslipidemia, and chronic inflammation. Despite improved outcomes with therapies such as SGLT2 inhibitors, gaps persist in understanding stage-wise cardiovascular risk across DKD progression. This study evaluates cardiovascular risk factors, cardiac status, and morbidity across DKD stages in a tertiary care setting to clarify these associations. This is a prospective cross-sectional observational study conducted on 193 patients diagnosed with DKD over 1 year at KMC Manipal. Objective was to assess cardiovascular profile in patients with DKD and evaluate cardiovascular risk factors such as IHT and heart failure in patients with type 2 Indian diabetes. 193 DKD patients were screened and demographic information, diabetic status, cardiovascular parameters, lipid profiles, ECG and echo findings were collected. Data was statistically analyzed with a statistical significance set at p less than 0.05. Inclusion criteria was patients admitted to hospital with DKD, age 18 and above, and patients with type 2 diabetes. Data was categorized into 5 stages according to GFR, calculating using the Cohort formula. Exclusion criteria was history of other cardiac diseases, history of other causes of CKD, and drug-induced renal failure or cardiac diseases. So the baseline characteristics were majority of the patients were in advanced CKD stages, especially in CKD stage 5. Mean age increased with CKD severity, and duration of diabetes increased with advancing CKD, highest in stage 5. Diabetic control status showed no significant association with CKD stage. Smoking was significantly associated, while alcohol consumption showed no significant association. Lab findings, FBS and PPBS, mean FBS and PPBS was 144 and 208, which showed no significant association with CKD stage. HbA1c showed a borderline trend towards significance. Triglyceride levels showed a strong significant association with CKD stage. Results, primary outcomes, cardiovascular parameters like left LVH was observed in 65% of participants and 77% had left ventricular dysfunction, including 42 with systolic dysfunction and 58% with diastolic dysfunction. Significant RWMA were noted in 34% of patients and valvular abnormalities were found in 91% of CKD stage 5 patients. ECG findings, connection effects like LBBB and RBBB were seen in a small percentage, and MI was present in 7 patients. Secondary outcomes. Risk factors like smoking was prevalent in 28.4% of the study population, with a significant correlation between smoking status and CKD stage with P of 0.033. BMI also showed a significant association with CKD stages, with a higher prevalence of overweight and obese individuals in CKD stage 5. Diabetes control. Glycemic control, as assessed by HbA1c, showed a mean value of 7.8% with suboptimal control in many patients, emphasizing the need of effective control to prevent microvascular and macrovascular complications. Lipid profile. Triglyceride levels were significantly higher in CKD stage 5 compared to earlier stages, while LDL levels showed borderline significance. Discussion. In our study involving 193 patients, they were categorized into 5 stages according to eGFR. Majority of them were in CKD 5 and CKD 4 stages, respectively. As this is a cross-sectional study with possible selection bias, distribution of CKD patients across CKD 1 to 5 in this study may not reflect the actual CKD burden in the country. As we can see here, cardiovascular profile with age and gender. Mean age of patients in the study was 58 years, similar to an Indian study by Anil Chandi, which was 57 years, and a large Italian study by Salvatore reported a higher mean age of 66 years. CKD stage 1 patient had a mean age of 49, while in stage 5 patients had a mean age of 59, suggesting increase in age may contribute to progression and worsening of DKD. CV profile with BMI. Patients were categorized as normal BMI and overweight or obese, and their distribution was analyzed across CKD stages 1 to 5. A significant correlation was found between BMI category and CKD stage. As we can see here, the proportion of overweight or obese individuals increased progressively from CKD stage 1 to 5, giving us an insights into the anthropometric profile of DKD, and the 48% of participants in the study were overweight or obese, which was comparable to 44% reported in a similar study by Quinn Limlow. CV profile with sugar parameters. Mean HbA1c in the study was 7.8%, which was comparable to Salvatore's study in Italy, which was 8.1, and Unikrishna's study in South India, which was 7.5. Similarity may be due to comparable study population profile. However, there was no statistically significant association between glycemic parameters and stages of DKD, suggesting that CKD progression doesn't only depend on glycemic parameters, but it's multifactorial. Cardiovascular profile with lipid profile. Mean triglyceride levels was 166 mg per dl, and LDL level was mean LDL level was 79 mg per dl. LDL showed a borderline significance with a P of 0.056, and triglyceride levels were significantly associated with cardiovascular risk. The LDL levels in our study were comparatively lower when compared to other studies conducted by Mora and Salvatore, implying the use of, probably due to the use of high-intensity statins and better patient compliance. CV profile with ECG findings. Higher prevalence of LVH was observed in advanced CKD stages. Up to 80% of DKD patients with LVH had an eGFR less than 30 ml per minute per meter square, indicating higher CV risk in advanced diseases reflecting chronic pressure overload and adverse remodeling. Incidence of LVH increases with longer duration and progression of DKD. Compared to Maura studies, this study showed higher LVH rate, possibly due to 96% of our patients having coexisting hypertension. 2D echo findings. Mean EF was 55 plus or minus 9% with minimal variation across DKD stages, comparable with other studies conducted on 452 diabetic nephropathy cases and Egyptian study, suggesting that EF remains largely preserved in DKD and may not reflect the CKD progression alone. This LV dysfunction. 77% of the study population had LV dysfunction, out of which 42% had systolic and 58% had diastolic dysfunction. And LV dysfunction worsened with DKD progression, most of the cases being in CKD stage 5 and 4, maybe due to increased cardiac workload and structural changes. However, no statistical significant association was found. LVH was prevalent in 65% of patients with statistical significance of P.04. Regional wall motion abnormalities. 34% had regional wall motion abnormalities on 2D echo, which was more common in advanced DKD, with many of them showing global hypokinesia with a significant association with P of 0.027, indicates a high burden of cardiovascular disease in advanced CKD, possibly due to ischemia and myocardial fibrosis. Coronary artery disease was prevalent in 41%, slightly lower when compared to other studies, because could be due to our stricter criteria for defining IST patients, and we didn't include the patients with LVH alone. So our study limitations of it being a cross-sectional design, and we have used Cockcroft formula for GFR estimations, and our findings may not be entirely generalizable given the tertiary care setting of the study and lack of data on medication. So to conclude, diabetic kidney disease is not just a renal disorder, but a progressive cardiovascular disease. Structural and ischemic cardiac abnormalities increase significantly with advancing CKD, making early and routine cardiovascular screening essential to reduce morbidity and mortality. Thank you.